one patient's data, right, condemned a generation of men being treated, multiple generations of men being treated for testosterone replacement therapy. Flawed retrospective data, again, continued that with cardiovascular stuff, and 91,000 premature deaths in women, hundreds of thousands more. So guys, I got an email the other day. It was such a good email from a student of ours here at HRT University, and it just totally blew me away. And I wanted to share it with you because I think it's also going to help you guys understand some of the philosophy of where we come from with HRT University, even when it comes to things outside of HRT. So before I do that, I am going to take a break to announce that I'm still not sponsored by San Pellegrino, but I am going to enjoy one of their very delicious blood orange fizzy drinks, bubbly drinks. So good. Oh my goodness. It lights up my universe. It's so good. All right, let's get into this whole thing. So I got this email the other day from an amazing student and colleague of mine, and I'm not going to name her, but she probably knows who she is. And she asked a really, really good question. And it was a question that I was like, I know I can answer. I know I can answer this, but like, how am I going to answer this? Basically, she said something along the lines of, hey, Nico, I saw something recently on your, I think it might have been Instagram, social media or something, talking about peptides. And she was like, you're the guy who kind of calls out some of the pellet stuff. Not that, again, that's going to sound like I'm like a pellet hater, but I'm not. For those of you who are curious, I don't think they're the best option. Let's put it that way. I talk a whole lot more about that in the course, but again, you're the guy who's telling us to think critically through things. And so she was like, I'm really interested. Why are you in favor of peptides when especially the human data for some of them is kind of thin? The legal landscape is certainly iffy, although that seems to be changing in due time here with some of the current administration, especially in terms of the FDA. But anyways, it's a mess right now. It feels messy, and the safety studies kind of don't feel like they exist. And so anyways, I thought, wow, what a great question. And here's the thing. First of all, she wasn't wrong to ask that, right? There's no such thing as a dumb question in my universe at all. And that was far from a dumb question. But I think a lot of providers, unfortunately, don't feel like her and feel comfortable enough to ask these questions. And I'm so glad that she did, because I think we're all going to learn a lot from this. And so again, that kind of distinction is really what this whole episode's about. But the real question is, I think, are peptides proven safe in humans? Now, the global answer to this question overall is yeah. I mean, we use peptides every single day in medicine, all kinds of peptides: oxytocin, HCG, insulin, thymosin alpha-1. Like, we have tons of studies on thymosin alpha-1, tesamorelin, even sermorelin, which was previously FDA approved, right? We have there are many, 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 many more peptides. Of course, the classic GLP-1s and GIP and all that sort of stuff, the semaglutides and tirzepatides. So, broadly speaking, yeah, peptides have been around for a long time. They're very, very safe. Now, I understand there are some that are not, as clear as some of these other ones that have had some randomized controlled trials and observational studies, but I'm going to get into that a little bit. But again, here's the question I like to ask, or I like to think about. I think the real question is, when has waiting for a perfect evidence, right, the perfect randomized control trial to finally come out, when has that ever actually protected our patients and especially benefited them? And maybe more importantly, when has it cost them, right? What harm has actually befallen upon some patients because we've waited and waited and waited around for quote unquote evidence that we can hang our hat on? Now, again, I'm not disparaging randomized control trials. They're super important. I love a good randomized control trial, absolutely. But I'm also one of those guys who, at the end of the day, I'm not going to wait around on the perfect randomized control trial, because you'll never find one. And more importantly, I'm going to lean on the science, the mechanism, the pathways, what we do inherently know about things like, say, progesterone, for example, right? I'm going to lean into those things. here's a really good example. Progesterone is anti-cancer, at least according to some very light, monkey cell studies and even human cell studies. Now, we don't have broad data and randomized control trials, and I'm not saying, progesterone is literally going to cure cancer, protect you from cancer. But what I am saying is that there is evidence based on mechanisms and pathways. And just if you really understand progesterone, like we teach in HRT University, you'll recognize, in fact, progesterone is very powerful when it comes to, potentially preventing cancer and things of that nature, right? So if you've been in HRT for any length of time, you probably already know the answer to this. Maybe you just haven't applied it to peptides yet. So let's get into that, okay? So let's talk about maybe 3 times that we've got it wrong when we ignored the mechanisms and the physiology, okay? And of course, I'm going to get into talking about BPC 157, just in case you're wondering about peptides. But before I talk about BPC, I need to, again, highlight the history in our own field, because if you don't understand how many times hormone therapy has been declared, quote unquote, dangerous by people who just don't understand the mechanisms and the pathways and the outcomes, you can't possibly understand why I personally refuse to make that same mistake with peptides. Okay. So, this has happened literally 3 times and many more times, frankly, but there are 3 great and separate occasions where flawed data, misinterpreted studies, or a single, quote unquote, researcher's conclusions overrode all this reasoning and logic. And it really caused a ton of harm to our patients and patients before us. Every single time, the clinicians who actually stood their ground and understood the mechanisms and they kept on treating their patients, those guys were all vindicated. All of them. And I'm going to show you that. So let's take an obvious one. The first one to hit the books was testosterone and prostate cancer. That was ancient. Back in 1941, decades ago, the infamous Dr. Charles Huggins published a research study finding that showed that castrating men who had metastatic prostate cancer caused the cancer to regress. Interesting, right? It's an interesting signal. He also reported that giving exogenous testosterone to these men caused the cancer to grow. Okay, so at face value, wow, what a signal, what a find. The dude basically wins a Nobel Prize for this work. And for the next 60 years, the entire conventional medical world operated under a single assumption: testosterone causes prostate cancer. And what do we know now? Well, testosterone is literally not associated or causative of prostate cancer in any way, shape, or form. Okay? The conclusion that testosterone administration causes prostate cancer growth was based on results from 1 freaking patient. 1. Can you imagine that? Again, we lose ourselves. I talk about this all the time. Like human beings, we have, whether it's good or bad, horrible memories. Horrible memories. It's probably why we love having so many kids, right? We forget, like, wow, that's really hard, and we have 4 more. No, I'm kidding. I love kids. They're a blessing. But again, there's a super critical detail that was either totally ignored or forgotten for decades, right? And what happened as a result? What do we get? We get millions of hypogonadal men, miserable, suffering men from the ages of 30 to 100 who were denied testosterone replacement therapy. And they suffered, right? They suffered from all the fatigue, the depression, the sexual dysfunction, bone density loss, metabolic disease, increased risk of all-cause mortality. They were told that they couldn't have testosterone because it would give them cancer, even though their quality of life was totally trash and frankly probably outweighed the risk of the prostate cancer anyways. That's a whole nother subject. But here's the really fascinating piece. The physiology never actually supported the conclusion. if high testosterone caused prostate cancer, well, wouldn't we expect to see prostate cancer rates peak in young men versus elderly men when their testosterone's at their highest, not their lowest? Dr. Abraham Morgentaler, infamous Dr. Abraham Morgentaler, pointed that out. We never see that. I mean, testosterone and prostate cancer in young men is practically zero. It's almost unheard of. Prostate cancer is a disease of aging, right? The quip is, it's not a matter of if but when you end up with prostate cancer, right? It's an age-related disease when your testosterone is declining. So if testosterone actually fueled prostate cancer, wouldn't you expect men with the higher baseline level of testosterone to have cancer, right? Do you understand the logic there? So I thought that was fascinating because now multiple longitudinal studies have shown that relationship is legitimate, or not legitimate rather, right? And in fact, some data is what is now currently being discovered is suggesting the opposite, which is low testosterone was associated with more aggressive disease. Isn't that crazy? Dr. Abraham Morgentaler, what a cool dude, out of Harvard, spent years dealing with that myth, right? He was literally on the front line, so to speak. He was biopsying guys with low testosterone, normal PSA, found to have prostate cancer at rates equivalent to the general population with elevated PSAs. Again, the opposite of what Dr. Huggins' model predicted way back when. And then again, flash forward to 2023, right? So again, think about that. We're going from 1941 to 2023. We get the amazing Traverse trial. 200 men with hypogonadism, pre-existing or high-risk cardiovascular disease, randomized to testosterone gel or placebo. This is published in the New England Journal of Medicine. And what's the result? Testosterone replacement therapy was non-inferior to placebo for major adverse cardiac events. Okay, so forget the whole prostate thing now. Now we're talking about the heart, because that was the other myth. Well, testosterone causes, cardiovascular events, causes heart attacks and strokes and clots and all that kinds of stuff. Nope. None of that. Also, guess what else it showed? No increased risk of prostate cancer. Zero. And guess what the FDA did last year? They updated the label for testosterone products based on this data. And again, that took a few years to happen. So 60 years of fear is what we ended up with. 60 years of fear and providers who were not capable of making a decision for their patients based on science and rigorous data points suggesting the opposite, because they fed into this ancient study in the 1940s based on one patient. It makes no sense. The physiology is always told a different story. Always. And fortunately, there were men and women, amazing providers before us, who said, to hell with all that. I'm going to treat my patients. Because what is in the literature is not what I'm seeing in real life. And it's also not what I'm seeing based on physiology and mechanisms. See what I'm saying? Okay, so let's dive into, I know we mostly touched on prostate and a little bit on cardiovascular, but I want to zoom in a little bit more on the cardiovascular stuff, because again, I think it's worth really hitting on that. So again, even after the whole prostate thing is a total myth, and yet it's still pervasive today. Now we hit on cardiovascular disease. So between 2010 and 2014, we have these handful of studies suggesting that testosterone therapy might increase cardiovascular risk. Okay, so we have, again, heart attacks and strokes and all that sorts of stuff. So the FDA issues this safety communication in 2015, basically requiring manufacturers to add the black box warning label to what? Testosterone. And guess what happens to testosterone? Well, prescribing was zilch anyways, but it dropped even more. Okay. Not only can you get prostate cancer, you can also get, heart attacks and strokes. So again, men who needed treatment were told it was too risky. Does this sound kind of familiar to the whole peptide thing a little bit yet? Because that's kind of where we're going. So again, the studies that triggered the FDA warnings, they were inadequate, flawed. They were pretty small, really bad, like retrospective designs. There were some methodology problems that were probably not really well addressed or pointed out, right? Honestly, the European side of things reviewed the same evidence and concluded there was no consistent evidence for increased cardiovascular risk. It's so fascinating because we even saw that for the female side of things, right? The whole WHI thing, much of Europe was like, oh, well, that's because we were using non-identical hormones. Duh, why don't we use the bioidenticals? We know the mechanisms there. We'll get to that in a second. But again, what's the point? The physiology didn't support the whole scare tactic here. It improves practically everything you can think of. Insulin resistance and improves insulin sensitivity, reduces the visceral fat, improves bone mineral density, improves musculoskeletal system globally. It improves lipid profiles. It supports vascular endothelial function. In fact, it helps the velocity of blood flow. Right? It's almost mechanistically, mechanistically. Again, I'm not making a huge statement here, but mechanistically speaking, it's practically impossible that testosterone replacement therapy, true, adequate, optimal, dare I say, testosterone replacement therapy could cause clots. And the Traverse trial, again, going back to that beautiful Traverse trial, it really settled it. Because again, we looked at all these dudes and what happened. They were fine. Nothing happened. Like, we had no increased risks. In fact, we also saw improved outcomes, right? We see a decrease, relatively speaking, in all-cause mortality. Okay, so now that you understand the testosterone, the male side, the prostate cancer, the heart cardiovascular risk stuff, fantastic. So again, I want to tie this into peptides here in a second, but I need you to understand history first. Okay? I know you were like, I didn't know I was showing up to a history lesson with Nico, but you are. Sorry, I'm just taking a sip of this delicious Sandpel because I'm parched. Now, let's get into the kind of third part of history here. Okay, because when we have this historical context, right? What's the famous line? If you fail to understand history, history will repeat itself, kind of thing, right? And that's again what I'm seeing a lot of in medicine. And this is why we have to respect what evidence is there. Of course, we have to respect that evidence. We have to understand it. But more importantly, we can't be shackled by it, right? We can't be chained by it. We have to be able to say, as providers, as clinicians, as scientists, right? We all got a bachelor's in science and a master's in science, and many of us went on to get doctorates in science of some sort. We're scientists. We have to be able to act as scientists, okay? So let's talk about the third thing, the infamous WHI. Back in 2002, that makes me feel old. The NIH basically holds a huge press conference, and they announce that they are stopping the infamous estrogen plus progestin arm of the WHI trial, and they're ending it early, right? And the message being, this clear message, which was hormone replacement therapy causes breast cancer, heart disease, and stroke, and the risks outweigh the benefits. Stop prescribing it. Take your hormones, flush them down the toilet. It's over. Sorry, ladies. Right? And that's literally what happened. Now, again, practically speaking, before the WHI, HRT was still not popular. Like, just to be clear, HRT has never been that popular for either men or women. But what amount of HRT was being done, I mean, practically just stopped dead in its tracks, right? The docs and NPs and everybody stopped prescribing. HRT use, I think it dropped almost as much as like 80%, which is bonkers, right? So, I mean, basically goes non-existent. And an entire generation or more of women, it's more, but let's just focus on the generation that was specifically affected by WHI. They were told that replacing their bodies needed and they were no longer producing was dangerous. And again, I talk a whole lot about how I'm not in love with the synthetic non-identical hormones, but even when we pare that literature down to its roots, from a risk versus benefit standpoint, it's clear that the benefits do outweigh the risks. BHRT, in my humble opinion, is still the winner here. But anyways, let's get back to it. So again, we have the large fraction of conventional medicine saying we're done, it's over with. But the providers out there who understood that physiology and mechanism, the people who really deeply understood what things like estradiol and progesterone do for the body, they knew something was wrong with that conclusion in that study. But more importantly, they also recognized that, well, you're not even looking probably at the right hormones, because you know what? They're not hormones. Progestin and conjugated equine estrogen, that's what they were using in the WHI trials. Those aren't hormones. They're not. It's literally comparing apples to oranges. Okay? I have whole episodes on that if you want to get into that. But if you understood where I'm coming from, is that the providers out there who also understood that, well, what if we just use the bioidentical hormones that our bodies actually produce and look at the data there? It is very clear that this data is inconsistent. It is very clear that hormones are so necessary, again, just like testosterone for men. Progesterone and estrogen, estradiol specifically for bone density, for preventing Alzheimer's disease, for cardiovascular protection. The list goes on, right? Replacing it in women at any age, whenever they need it, is not inherently dangerous. It actually makes physiological sense, and those providers were right. They were always right, and they were considered absolute crackpots. Okay, and I know this because, practically speaking, when I was going through NP school, this is almost 10 years ago or more, I was working with some of these people who, again, they were prescribed. They've been prescribing HRT since basically the first time they started practicing medicine. God love these mentors of mine and these amazing nurse practitioners and physicians who stuck their necks out and got a lot of heat for it. They were considered total crackpots. Okay. They were quacks. They were dangerous. Now, granted, that still exists today, of course, like a lot of us are still probably considered that to some degree by a lot of them, but it's much different today than it was then, because guess what? All the data is now validating us. They were on the right side of history. Okay. More than, a decade, but certainly even longer than that, were women who were suffering and not getting helped at all, because providers out there did not really understand or appreciate mechanisms, physiology, the depths of the data, and really misinterpreting or understanding what things were being studied and why. Guys, these men and women out there who were saying no to HRT, they weren't studying hormone replacement therapy, okay? And I'll tell you this because none of us were taught this in school anyways. So it's not like we really even have a great foundation, right? If you're not taught something in great detail in school during your years and years of school, truly, then how could you possibly ever recognize when something is wrong or flawed? They again, here at best, these men and women, and again, this is NPs, PAs, MDs, whoever, they were studying what would basically be like late initiation of a non-bioidentical Franken hormone regimen in an elderly population. And they basically then extrapolated those results to every single woman on earth, every formulation, every age, right? And it made no sense to do that. Okay, when you looked at women who started HRT, true HRT, like bioidentical HRT, within 10 years of menopause, what did we get? Reduced coronary artery disease, reduced all-cause mortality, reduction in Alzheimer's disease and dementia, right? We got like a 40% reduction in all-cause mortality. in that younger cohort, right? Even in the WHI trial, we saw that. In fact, just to give the devil its due, conjugated equine estrogen, we saw a decrease in the risk of breast cancer. So all that to say, we missed a huge mark and millions of women suffered for it for no reason. So think about this. This was a study that was published in 2013, and it estimated that somewhere in the ballpark of like 90,000 American women died prematurely between 2002 and 2012, where there was some shakiness with HRT due to the WHI, because we completely avoided just estrogen therapy alone. And there was another analysis that was done by like Yale, and it put this is crazy. It put the number of premature deaths from estrogen avoidance in post-hysterectomy women around 50,000. So, okay, what is that? 90,000 women with an additional 50,000 women because what? We let a totally flawed study, a poor understanding of what we were really looking at, override what is just good old-fashioned physiology and mechanisms. Okay, so do you see this pattern, this historical pattern? 3 different occasions, and there are many more. I'm just naming the 3 that I think are probably the most relevant. We had the testosterone prostate cancer, testosterone cardiovascular disease, all the stuff we had with the WHI and HRT bad and going to cause cancer. And what did we end up with? People who died way too young, people who died and suffered, right? Not just lived a life of disease, but suffered with that disease for decades. Thousands and tens of thousands of people. I'd argue, again, if we're talking worldwide, it's millions of people because of what? Our inability to see past a couple crappy studies, or not willingness to dive a little deeper. And again, the only people who dare to say, I respect these studies, I understand their importance and their relevance, but there's something wrong. It doesn't add up because this does not match with my deep understanding and my current and concurrent and recurrent learning of physiology and mechanisms, and having a framework that makes this make sense. And those were the people that were proven right. And guys, they're not smarter, okay? I'd like to consider myself as one of those people. I'm telling you, like, I'm not the smartest person out there, believe it or not. Right? I get things wrong all the time. I say stupid things, right? I'm not saying that. What I'm saying is, I think those of us who are willing to think beyond these, what are almost tabloid headlines of studies, we will be the ones who push the needle forward for our patients. And you have to have a little bit of bravery to do that. You have to kind of be willing to, break some of the rules, go against the standards of care in order to do that. Okay? This episode ain't over yet, guys. I'm just getting cooking. I am just getting started. Because now we got to talk about how this ties in with peptides. Okay, so let's talk about peptides. If you understand what I'm saying here, the lesson is not those studies were wrong, but the lesson is just going to be a little bit deeper than that, right? The lesson is, at face value, evidence-based medicine applied without any physiological reasoning or clinical judgment or the willingness to kind of think through this stuff, it's going to cause massive harm. And the absence of a perfect randomized control trial or observational study or whatever is not the same thing as the absence of evidence. Okay? I'm going to say that again. The absence of a perfect, which doesn't exist, randomized control trial is not the same thing as the absence of evidence. And if your whole worldview is you must wait for perfect data while concurrently you have strong understanding and mechanistic science stuff. You have consistent preclinical findings, early human signals pointing in the same direction. That is not dangerous in and of itself. It is a choice, though, okay? It is a choice. And as we've seen, that choice has consequences. And this is where I appreciate those of you who are like, Nico, what the heck, dude? Like, how can you be so confident about peptides that have no randomized control trials? Because I make a choice and my patients make a choice. We make a shared decision around this choice. Yes, it's experimental. Yes, there are risks. Okay, but I'm giving you what I know. And what I know is that there is caution for those patients, potentially if I do nothing, just like we did with HRT and TRT, right? So let's talk about it, okay? And I want to highlight BPC because again, we have lots of peptides that have a lot of, I think people like to clump peptides into this like wild west category. I would actually argue that most peptides have a lot of clinical data behind them. Okay, there are some that don't, and one of those would be, and especially if we're talking human clinical data, one of those would be BPC 157, which is also by far probably one of the more popular peptides besides the really big ones like the GLP-1s and stuff, okay? So for those of you who are like, Nico, I don't even know what you're talking about, let me just kind of give you a little breakdown. So remember, BPC 157 stands for Body Protection Compound 157. Again, it's a peptide. It's just a chain of amino acids. That's it. 15 little amino acids strung together. And here's the first thing I want you to know. This is important. BPC 157 is not an exotic molecule that was literally invented in a lab. Okay, there are some peptides that are more along the exotic lines, right? So to speak. But the, overarching parent compound of BPC naturally occurs in your belly, in your gastric juice. Your stomach produces a protein that literally contains this 15 amino acid sequence. What does it do? It protects our gut. It helps our gut repair itself. And so what researchers did was they isolated just that sequence and they did synthesize it just like we synthesize testosterone, right? And this has been studied since like the 90s. Okay? I mean, the parent compound even further before that. So it's not new. If you understand the history, which is important, it's not new. And so what does this thing do? Again, think of BPC as a healing peptide. When you get injured, and it doesn't matter if that's a peptic ulcer or a torn ligament or tendon, whatever your body has to do to heal, it has to do a few things, right? It has to do what? Literally, it has to help grow new blood vessels to that site of injury. So we can do what? Bring more oxygen, more nutrients to the damaged area, clear inflammation. What do we call that? Angiogenesis. It needs to calm down the whole inflammatory response because, again, we don't want inflammation to be this chronic thing. We want it to be there, and then we want our body to respond to that, and then we want it to go away, okay? It needs to recruit all the things, the right cells and the right circumstances to rebuild that tissue. And it has to stabilize the lining of those blood vessels and the tissue barriers so that everything holds together really nicely during that repair process. And BPC 157 appears to support all four of those kind of processes. Okay. So if you want me to get a little nerdy here, hang on with me. BPC 157 activates something called VEGF, right? Which is, again, that grow new blood vessel switch is what I like to kind of think of it as. I like to simplify these things. We use such crazy terminology in medicine, but VEGF is literally just an endothelial growth factor for blood vessels, right? So when that receptor gets turned on, it triggers that downstream cascade. It helps us produce nitric oxide. It helps dilate the blood vessels, and then it improves blood flow, and then it supports the formation of new vascular networks and all that cool stuff. So again, if you're into HRT and you already know like the whole nitric oxide benefits of some of the things that hormones do, well, it's the same molecule technically that's doing the whole healing thing, but now it's just on the peptide side of things, right? And the way that it does that is through that VEGF platform via being initiated by BPC. So BPC also, remember, inflammation is a big thing here. So BPC dials down inflammation. It reduces, inflammatory activity of different biomarkers, which is, hugely important when it comes to, again, inflammation being acute versus chronic. So it reduces the, activity of NF-KB, which is like one of our master, inflammatory switches. It activates the growth and repair pathways, which is like ERK1 and ERK2. And that does all kinds of things. It tells cells to divide, to migrate, right? To literally migrate tissues together so that they can repair themselves if something's torn, right? We want to push those tissues back together. But here's what makes, again, BPC so freaking insanely cool and very unusual is that most things that promote healing work in one tissue type, they're good for maybe tendons, or they're good for the gut, or they're good for muscles, right? It's rare that it's good for all of them. But BPC 157 has really consistent effects across basically any soft tissue type that has ever been tested. So again, tendons and ligaments, obvious ones, muscles, bone, cornea, gut, blood vessels, nerve tissue. That is super, super uncommon. And so again, that kind of cross tissue repair consistency is rare. And again, it suggests that this compound is working at a very fundamental and foundational level of cellular repair, right? Than just being super hyper specific to one tissue or one organ. And I think that's super interesting. And so again, if you're understanding what I just described, then you understand why researchers have been in love with this stuff and have been studying it for, the better part of over 30 years now. Okay. So again, when we're kind of thinking back to that initial question that student asked me, right? It's mostly around safety, which is fair, right? We're providers. We don't want to hurt our patients unknowingly. That is really important because we've seen that too, right? So this goes both ways, right? We've done, remember back in the 90s when it was like, oh, oxycodone's totally safe. It's not addictive or whatever, right? Like we've seen those things happen too. So we ought to have a healthy level of skepticism and fear and anxiety around this stuff. So I'm with you there. But again, a lot of times that's just us saying, I don't know of any safety data, or I've not seen it, or maybe I've seen some, but I've maybe just not, kind of pushed it all together. And so I want to just present this to you. Pretend I'm a lawyer. I'm Courtney Walker, for any of you who know Courtney, right? I'm not at all. But I'm going to play Courtney Walker. I'm going to try to, and I'm going to try to be as halfway as funny and charming. But let's look at just what some of the data out there is actually saying, because I'm a data guy too. I'm a dork. I like to know this stuff and I want to make it make sense. So let's talk about preclinical data. Now, again, it's in the word preclinical. I'm not saying that this is a randomized double-blind control trial or anything like that. I'm talking about preclinical data. But back in 2020, a research group published what I think is probably the most thorough preclinical safety evaluation of BPC to date. They tested it across 4 species. Okay, so not humans, mice, rats, rabbits, and dogs. And they looked at basically single dose toxicity. Can we, which is so morbid, like, can we kill any one of these animals with BPC? So they looked at single dose toxicity. If I give 1 dose and they die, repeated dose toxicity. How many doses of this can they get until they die? Local tolerance, allergic reaction, genetic toxicity, And they even looked at the effects on developing embryos, right? So whether or not this stuff is teratogenic, is it going to hurt the baby? And what results did they find in the most straight up fashion? Nothing. Nothing happened. No deaths at any dose, which is crazy. Okay. Like, I mean, that is so rare. In fact, there are very few things that we know don't have a non-lethal dose. Ironically, some of the other ones are like some of the classic psychedelics, like psilocybin, for example. I'm not saying you're not going to have a bad trip on that stuff, but there's no known like toxic dose. But at any rate, what they found was no deaths at any dose, no organ damage on any autopsy, no genetic mutations, no birth defects, no allergic reaction, like nothing. The only finding of any kind was like a slight decrease in like one kidney marker in a dog at the highest dose. And it resolved on its own in 2 weeks. Okay. That's it. Which again, like we could even say, was that even BPC, right? So there are multiple review papers that have also, by the way, confirmed the same conclusion. So again, across 30 years of research and across a huge range of doses, again, granted they're animals, nobody has been able to find a dose that causes harm. And that's our biggest fear, right? Is this going to cause harm or not? They literally could not establish a toxic dose or a lethal dose in any new species tested. And to clarify, all medications and things of that nature have to go through this. We give Tylenol all the time to people. And that is a very lethal drug. Extraordinarily lethal. Ibuprofen is lethal at doses, right? It will just destroy your kidneys. They couldn't find that with BPC 157 in any of these animals. Okay. Now compare that again to everything you prescribe, guys. Try to name another compound where researchers tested it across 4 different animals at doses hundreds of times higher than clinical use and found 0 toxicity. It's so clean, it's bonkers. Okay. All right. So I know what you're thinking, because if you're like me, you're like, nah, that's cool, but it's still animals, dude. What about humans? Okay. Let me be clear. First of all, there is human data, but it is limited. And I'm not going to pretend that it isn't. And I'm not going to pretend that, especially one of these studies, is kind of hokey, but I just want to get into it. Okay. As of right now, again, it's still early on in 2026. In fact, it's the first day of spring when I'm recording this. We have had, I think, 3, at least from what I can find in the literature, 3 published studies, human studies, and they all have, usually under 30-ish people in between them. Okay. So, but let's just highlight them because it's important, right? We have to take this holistically into account. So in 2021, there was a pilot study on knee pain. This is the study that I think it's kind of junk. Okay. It was out of a clinic doing kind of the regenerative med stuff. So again, sort of biased. 16 patients, super small. They all received BPC 157, like intra-articular, I can never say that word, intra-articular injections for knee pain. 14 of them reported significant relief. 6 to 12 months later, they reported no adverse events. Okay. Again, small study, probably a little biased. Coming out of some tiny clinic, whatever. But hey, let's just take it for what it is. There was no adverse effects, okay? Or events. Small, tiny, we could practically throw it in the trash, but it's there, and I just want you to know it. It does get a little bit better, okay? So in 2024, there was a pilot study on interstitial cystitis, and this was, I believe, a phase 2 trial, okay? So again, we're pushing into the like, hey, we really want to see if we can use BPC as a legitimate medication. Again, small study, 12 patients, but pretty big signal, 80 to 100% symptom resolution from interstitial cystitis with BPC 157. And again, no adverse events, 0. Pretty cool. I think this one, which is newer, this last study is I think maybe one of the most telling things. So back in 2025, researchers did an IV safety study. Okay, so we all respect IV, right? Remember being a nurse or a doctor or whatever you are. If you've ever given oral Tylenol to patients, you might as well just give them a placebo, in my opinion. Like, it doesn't do anything. But IV acetaminophen, hot dang. That stuff works, right? That stuff really, really does work. And so we respect that. Man, when things go IV, it's hitting hard and it's hitting fast. Okay. So again, safety study, again, tiny, even smaller. There were just 2 adults. Okay. 2 otherwise healthy adults received up to 20 milligrams intravenously, BPC 157, and they had all the comprehensive monitoring of their heart and liver and kidneys, thyroid, metabolic function, the whole 9 yards. What'd they find? Nothing. 0 adverse effects. So just to clarify, what is like a typical dose of BPC 157? If we're using it more clinically speaking, either oral capsules, usually about 500 milligrams to 250, or I'm sorry, let me repeat that. 500 micrograms, sometimes as low as 250 micrograms. That same dose is also used for subcutaneous injections, which is probably the most popular way to give peptides, right? They used 20 milligrams, okay? So we're moving from micrograms to milligrams. 20 milligrams IV, nothing, no adverse effects, 0 meaningful changes. Okay, so let's back up here. Is that enough for definitive conclusions on BPC? Of course not, guys. Come on. Of course not. But are we getting some signals here? And if we understand some of the mechanisms, and if we pull in all the animal research that's been done and all the studies that have been done, what we're getting is 0 adverse events in every human study. Any human who's ever been formally studied, combined with 30 years of animal data showing no toxicity at any dose. This is not like dismal information. In my humble opinion, it is not no evidence. It's little in terms of the human stuff. It's early evidence, and it appears to have a very clean safety signal. Okay? And those are different things, right? They just are, fundamentally. And this is why I want to maybe challenge how a lot of you are thinking about this. There's a mindset in medicine, it's pervasive, and it goes like, if there isn't a large randomized, double-blind, placebo-controlled human trial, we can't say it works, and we shouldn't use it, period. End of story. Now, on the surface, that does sound really good. It sounds really responsible. It sounds very rigorous and scientific. And I appreciate that. I really do, because I stand by that. But I want to back up a little bit, because when you actually examine that standard and apply it consistently, it kind of falls apart in the real world. Let me give you some examples. Testosterone therapy for women would be a great example. Currently, as I sit here today, there is no FDA-approved testosterone product for women in the United States. Not one. 0. The evidence base consists largely of observational studies, small trials, some clinical experience. And yet, if you practice in the HRT space like me, and you're prescribing testosterone to women every single day, and like my mentors before me who've been prescribing it for decades, why? Because the mechanisms make sense, because testosterone is an innate part of the human body for both men and women, because clinical outcomes are consistent across the board, and because waiting for a freaking randomized control trial is just going to mean we're denying a treatment that clearly helps our patients. Right? I mean, compounded, if you're doing compounded hormones in general, right? I talked about this on my last podcast, like compounded hormones in general, the majority of bioidentical hormone prescriptions in this country are compounded. And compounded basically means non-FDA approved. It means no standardized dosing. It means you're relying on clinical judgment, lab monitoring to some degree, and truly, if you're an HRT University guy or gal, the mechanistic understanding and deep appreciation of these hormones rather than a phase 3 trial, straight up. And we do it every day. Why? Because we understand the physiology so well, right? We know it. We feel so competent that it means we feel now confident to practice intelligently and autonomously within that framework for our patients so that we can make a shared decision. What about the evidence we just talked about earlier? Dr. Huggins, he told us testosterone causes prostate cancer based on one freaking patient. Like, how is that better than the whatever, 12 or 14 patients with the knee injection of BPC or the interstitial cystitis or the IV stuff? Literally, I'm sitting here. How? Doc Huggins tells us testosterone causes prostate cancer based on one freaking patient, and it took 60 years for us to correct over that. 60 years for conventional medicine to get to the point. I'm arguing here because it hasn't. Because if it had, it would mean that every single urologist in America would be prescribing testosterone, and they don't. Right? These flawed retrospective studies told us testosterone caused heart disease, heart attacks, and strokes, and clots, and all the scary stuff. And it took the freaking Traverse trial to settle that one. And again, I don't see any cardiologists prescribing testosterone, even though it has amazing outcomes for the cardiovascular system. How about the WHI? Hormones kill women. Well, yeah, not at all. And by the way, especially not the bioidenticals, for all that I care. It took way more than a decade, essentially at this point, for the reanalysis to discover that hundreds of thousands, if not millions of women worldwide died premature deaths and suffered. In every single one of those cases, every single one of them, the people who kept prescribing weren't being reckless. Okay? They were the ones who understood the importance of the mechanisms and physiology to see that these trials, their conclusions didn't match. They didn't add up. There is no logical sense behind them. And when they actually looked at what these hormones do in the human body, just like we look at peptides and what they do in the human body, they say this doesn't make sense. And they were the ones who were right every single time. So here's my question. Again, how is that truly any different from what many of us are doing with BPC 157? Especially, and this is important, you have to give informed consent. Duh. This is an experimental thing, okay? It is not FDA approved at all. It's purely experimental. The data we have on humans is limited. It's small. Okay? We're telling patients the truth. We're giving them informed consent. We're not making stuff up. That is not appropriate. Okay? I mean, I had to do the same thing with testosterone. I had to say, look, for years I had to say, I had to tell these patients, even though mechanistically and physiologically, and even in some other studies, that testosterone appears to be totally safe and does not in any way, shape, or form appear to have the ability to cause prostate cancer or heart attacks. I have to legally tell you, and I did every single time, even though I felt like I was biting my tongue, that there are studies that exist that say that testosterone does cause heart attacks. And now, 10 years later, I get to tell patients, actually, that was all make believe. None of that was true. Right? So again, I have a compound derived from a protein already present in the human body called BPC. I have 30 years of preclinical research showing consistent tissue repair effects off of every system tested. I have a safety profile that is literally cleaner than practically anything I'm prescribing, even hormones, right? Or even vitamins and minerals and Tylenol and whatever off the shelf. I have more safety. I have early human data with no adverse events at all. And I do have a well-characterized mechanism of action that makes physiological sense. If I look at that holistically, right, and say I can't touch it because there's no randomized control trial, well, then I think, this is my personal opinion, that I am making the same mistake as the conventional medical establishment made with Doc Huggins, with the retrospective studies for cardiovascular events, as like the WHI. I'm making those same mistakes. I'm letting the absence of one specific type of evidence override literally everything else I know. I am. And I personally, as I sit here, I refuse to do that. I've always kind of been that way. And it's not because I'm reckless or I like being cowboy and wild and crazy. I don't. I'm actually quite conservative, believe it or not, when it comes to that stuff. The reason why I know that that is not the case is because I've also seen what happens on the flip side of that. Okay? But the reason I feel so confident is because I know the history, and 3 times in the field that I love, the cost has been measured in what? Patients denied treatment and costing them their lives, literally. And costing patients their lives, it doesn't just mean they die early. It means they suffer for decades. Think of the women suffering from major depressive disorder. And all it was they just had no estradiol, no progesterone, no testosterone, no thyroid. Right? Think of all the men who suffered from, the ravages of cardiovascular disease because their lipids went to hell in a handbasket because they didn't have testosterone. And then they had to get on a statin, which made their muscles ache. And, where are we going with this, guys? The cost is super, super real. And I think it just takes that bit of, not bravery, but true clinical understanding to make the biggest difference. So I want to make one point, because some of you, again, are skeptical, and that's okay. That's okay. But you're skeptical of BPC 157. But again, very much comfortable with things that have much more documented record of harm. So there's a cognitive dissonance in some ways, even a double standard, a cognitive bias that is baked into our heads. I mean, that's what the Huggins thing was for 60 years. It was just pure cognitive bias. It was just schools telling providers, don't ever give testosterone. Why? Because prostate cancer. And nobody dared to look into it except for a few brave souls. Okay. We have a lot of data suggesting the safety and the rigors and all those sorts of things. Okay. BPC, there's no toxic dose to it. There's no organ damage. Okay. And again, I'd like to highlight BPC. I'm not giving every peptide my condolences. Okay. Just to clarify, I'm not speaking for all peptides here. I just wanted to highlight one that especially doesn't have a lot of the human studies and randomized control trials around it, because I think if we just, again, wrap our heads around that, we can start then looking at other peptides as we should. And I'm working on a course. I'm working on a course actively right now for peptides. And there's a lot of changes going on right now. I'm sure it's going to be like that forever, with the FDA and whatnot. So I'm also kind of waiting to make sure that, if any changes are made recently, I can make those changes. But at any rate, I'm making a course on peptides that will mimic the thoroughness and the excellence that you all expect from HRT University. Right? Because if you've taken the master course, you've seen the depths and how so many providers appreciate that because they feel so much more confident. Well, I want to provide that. I want to do that with peptides because I think it matters so much. Okay. I think that's going to make the biggest difference. I really do. So again, here's the framework again that I'm using. And it's one that I use inside HRT University. Again, it's not always going to be about whether there's a randomized control trial to solve for this. It's also going to be about asking the right questions in the right order. Question 1, does the mechanism make sense? Again, that's where that physiology first thinking matters. It matters so much. If someone hands you a compound and says it works, but we don't know how, that's a huge red flag. Okay. And guys, look, almost every compound, even testosterone, we know a lot of what it does, but there are things we still don't know about testosterone. So again, it's not the end all, but a green flag is if they hand you a compound and you can map out the mechanism through some known amount of biology and there's history behind it. That's a green flag. It doesn't always mean proof, like legitimate 110% proof. It means it's a green flag. Okay. Question number 2. Is there preclinical data that exists and is it consistent, right? Are we getting jumbled messes of like, well, it killed this animal, but this animal lived, but at this dose it's lethal? Again, one study in one animal model doesn't mean much, but 30 years of studies across multiple species, tissue types, routes of administration, crazy different dosing with consistent findings, that means a lot. Again, it doesn't replace randomized human control trials, but it builds a really strong foundation of biological plausibility. And that is really, really, really important and hard to ignore. Okay. Question number 3, what does the safety profile look like? And is it proportional to the intended use? Again, for BPC 157, the safety margin is insane. It's enormous. No toxicity at any tested dose in any species through any route of administration thus far. It doesn't mean it's proven safe in humans for long-term use. Important. But it means the preclinical safety signal is about as clean as it gets. Okay. And when you combine that with some of the early human data showing 0 adverse events, I think that puts in a bit more favorable when it comes to risk calculating. Okay. For short-term targeted therapy with true informed consent. This is experimental. Okay, so we're not sugarcoating any of this. The 4th question, what is the regulatory and legal landscape? That matters so much. I have a whole podcast on that. I did it with Courtney Walker, speaking of. If you go back into the podcast, you'll find an episode where her and I talk about the legalities around peptides. Okay, right now, as it stands, again, BPC is currently classified as an FDA Category 2 medication or compound, meaning it can't legally be compounded by commercial pharmacies, which I know is confusing. It's not, just to clarify, it's not a DEA scheduled controlled substance. Okay. It's categorically different. The legal gray area is very real and you need to understand it before you get involved in your practice. And again, I'm imploring you to go back to that podcast I did with Courtney because I talk all about this. Again, this is about protecting yourself and your patients, and it really is not about the science at that point. Okay. But there is legality around it. There is a landscape to it and you have to understand it. Question number 5, Can you have, this is probably one of the most important questions, can you have an informed conversation with your patient about what we know and what we don't? This is the one that separates really good clinicians from super crazy reckless ones, and the ones who frankly put a bad taste in my mouth and all of ours, okay? If you're prescribing and providing BPC 157 from a legitimate source, which by the way, currently as it stands would be a 503A compounding pharmacy, and you're telling patients it's proven safe and effective, right? I know that sounds so confusing. What I'm saying is you can't just say that and be done. That's not informed consent. If you're refusing to discuss all the other things, right? Like it's experimental and blah, 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 you're failing them. And that is not informed, that without that, that is not informed consent. Okay. The right answer is always give informed consent. Here's what we know. Literally all of it. Here's what we know. Here's what we don't know. Here's my assessment as your provider of the risks. Here's why I think it's worth considering for your specific situation. And let's try to make a shared decision together. That's medicine, folks. That's always been medicine. We are not shackled by a lack of a randomized control trial, but we are respectful and understanding that those things matter. And without them, we can't just say BPC 157 is some sort of unicorn miracle molecule. It's going to fix everything. That is wrong. That's practicing medicine, guys. Okay. So I'm gonna kind of bring this home because I know you guys need to get out of here. You've been listening to me yap. The lesson of this episode, I hope that you're moving away from this episode with, is go prescribe the crap out of BPC 157 to everybody and their grandmother. That's not the lesson here. And it isn't altogether peptides are 100% the future. Okay. I'm trying to be balanced here. Maybe they are. Maybe they aren't. The data is going to tell us over time. Okay. But the lesson is about how you think. Again, if the WHI and the Huggins myth and the TRT cardiovascular scare taught us anything about history and medicine, it's that evidence-based medicine is only as good as the thinking behind it. Okay? A bad study, interpreted poorly, applied universally to everything and everybody, can do way more damage than no study at all. One patient's data, right, condemned a generation of men being treated, multiple generations of men being treated for testosterone replacement therapy. Flawed retrospective data, again, continued that with cardiovascular stuff. And 91,000 premature deaths in women, hundreds of thousands more. And on the other side, waiting for perfect evidence while patients suffer isn't noble or ethical or anything. Okay? It's a choice and it has consequences. Every provider who kept prescribing HRT after the Huggins thing or after 2002 with the WHI, who kept prescribing this stuff, even though the evidence was pointing to cancer and cardiovascular disease risk and death and all that, they were all vindicated. And it's not because they were lucky. It's because they were thinking. They were thinking through it. And that's what I desperately want that for every provider who comes through HRT University, right? We don't want blind faith in trials. That's not healthy. I don't want blind faith in me. Okay. I don't want blind faith in trends or fads or any of that stuff. I want you to understand the physiology and read the data critically and apply a very consistent standard of evidence across everything you evaluate and make defensible clinical decisions for your patients. And again, BPC 157, it interests me because the mechanisms are so sound and the safety signal, in my opinion, is very clean. Early data is consistent with that. And by the way, the student who emailed me, she did exactly what she should have done. She questioned my position. She's looking for consistency, right? And I hope I in some way provided that today. I hope I didn't provide more confusion. And I hope this episode gave her and all of you something worth really chewing on. And if you disagree with me, that's a good thing. Okay. We can talk about it. That's how we get better. Right. So, folks, if you're inside HRT University and this episode fired you up, please discuss it, talk about it in the community. I want to hear what your thoughts are. And if you're not inside the HRT University community, this is what we do, right? We don't just hand out protocols and algorithms and tell you to just blindly follow them. That is not medicine. We teach you how to think. We give you frameworks based on actual physiology and mechanisms so you feel confident and competent in what you're doing. And your patients just love you for it. And you blow up in your community. Okay? Link in the show notes, folks. Please check out hrtuniversity.com if you're interested in looking at the master course for HRT. If you're like, Nico, dude, I love the way you think. I love the way you teach. I want more. Even if you've taken an HRT course before, I'm telling you, HRT University is so different. Okay. Check out my daily email is amazing. I talk about this stuff all the time. Okay. It's under Nico Misleh, np.com. It is in the show notes. Again, just opt in and you can receive the emails. We send them right now Monday, Wednesdays, and Fridays. It used to be a daily email. I cut back a little bit because I'm trying to work on all these other things for y'all. But again, I'm so thankful for you guys sticking around, asking these hard questions, and being curious. I love it so much, and I'm so grateful for it. So thank you all again for your time, and I will see you at the next episode.